Talk about the keys to saving a life when your patient is in cardiac arrest. The take-home message is chest compressions are everything. You don't get to ACLS without BLS. If you're not doing good chest compressions, nothing else matters. We're going to go through the algorithms and how I think about it, but first and foremost is good quality chest compressions. Minimize interruptions, making sure you have a good rate of 100 to 120 compressions per minute. Make sure that you have a good depth, that you're fully compressing the heart. Make sure that you're allowing for recoil, allowing that heart to fill back up. Chest compressions are everything. I really like to use end-tidal CO2 because that's a really good measure of how effective your chest compressions are. The take home for this whole lecture is chest compressions are the most important thing. Minimize the time you spend off the chest. And when your chest compressions are going, make sure they're effective chest compressions. So chest compressions. Then my priority, let's say this patient just came through the front door. I don't know what's going on with them. We're doing chest compressions. I've got good chest compressions. The second most important thing is early defibrillation. And so I have good chest compressions going. My second priority is getting pads on the patient. First thing I'm doing is directing somebody on the chest, making sure they have adequate chest compressions. Next thing, I'm directing my next available person to get pads on the patient and get them on the monitor. So with the pulse check, I can determine if this is a shockable rhythm. And that's where our algorithm starts for management of cardiac arrest. Is this a shockable rhythm or is this a non-shockable rhythm? And that's what we're going to talk about. First of all, let's look at our shockable rhythms. Our shockable rhythms are going to be V-tach and V-fib. Anytime you see this rhythm, shock the patient. 200 joules, asynchronized, shock the patient. Every pulse check, if you see this, deliver electricity. So 2 minutes of high quality chest compressions, I do a pulse check. If they're still in this, I'm going to shock and then immediately get back on the chest and do 2 minutes of chest compressions. So I'm going to teach you a little song that's going to teach you all about managing shockable rhythms. Shock, shock, epi, shock, amio, shock, amio. Remember that and you'll have it. Shock, shock, epi, shock, amio, shock, amio. That's the algorithm for shockable rhythms. So my first pulse check, if I'm in a shockable rhythm, I'm going to shock them. I'm not going to give epinephrine initially. If my patient is in V-tach, is in this rhythm up here, and they have a pulse, and I give that patient epinephrine, I've pretty much just killed that patient. If I have these rhythms with a pulse, epinephrine is absolutely the wrong answer. Just because you lose the pulse doesn't mean it's suddenly the right answer. So I'm going to get high quality chest compressions going, pads on the patient, and I'm going to defibrillate. Then, after 2 minutes of high quality CPR, if I'm still in a shockable rhythm of the next pulse check, I'm going to shock again. Shock, shock. Now, if this patient's been in a shockable rhythm, pre-charge your defibrillator. Tell your recorder, hey, when there's about 15 seconds before our next pulse shock, let me know, and we're going to charge the defibrillator so that I can get electricity through quickly and get back on the chest quickly. So I'm going to do shock, shock, and then I'm going to do 2 more minutes of high quality CPR. After the second defibrillation per ACLS, this is when you can consider epinephrine. So shock, shock, epi at this point. Make sure you give me at least 2 defibrillations before you give epi in a shockable rhythm. Sometimes I wait longer before I give epinephrine with shockable rhythms. That's me. At least follow ACLS. At least deliver 2 defibrillations before you give epinephrine. But per ACLS, shock, shock, epi. If I'm still in the shockable rhythm, I'm going to shock again. As soon as I shock, I'm going to get back on the chest. I'm going to do 2 minutes of high quality CPR. So shock, 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 epi, shock. At this point, you're going to give amiodarone. 300 milligrams IV bolus. So shock, shock, epi, shock, amio, and at your next pulse check, if you're still in a shockable rhythm, you're going to shock again. After that, you immediately get back on the chest with high quality cheap CPR, and you're going to do amio again, this time 150 milligrams. This is the algorithm. If you can remember this, you can manage most patients in shockable rhythms. Shock, shock, epi, shock, amio, shock, amio. Sing it until it's stuck in your head. This is the algorithm for shockable rhythms. Shock, shock, epi, shock, shock, amio. And then if you ever get lost, just think about where we're at. Okay, we've shocked 2 times. Shock, shock, epi. Okay, let's get some epinephrine ready on the next pulse check. Let's be prepared to shock. You've shocked 3 times. Shock, shock, epi, shock. Okay, next is amio. Let's go ahead and give 300 milligrams of amiodarone at this time. You know, after this has failed, I look really closely, making sure I'm not missing a polymorphic VTAC, such as torsades, in which case I need to give magnesium. I'm considering hyper-K because that can throw you into ventricular dysrhythmias. It's rare, but it can happen, so I'm looking for any signs of hyper-K, and I might give calcium. But for the most part, this is going to take you through all your shockable rhythms. Shock, shock, epi, shock, amio, shock, amio. That's it. That's the algorithm for shockable rhythms. Now let's talk about the not shockable rhythms. So PEA or asystole. So the things I'll say is, first of all, if a patient's in PEA or asystole, they are likely not going to survive. Their survival to neurointact discharge is less than 3%, so not a great prognosis. However, if they have an easily reversible cause, then they have a really good chance if we identify it early and intervene early. The other thing I'll say is, if you think the patient's in asystole, look really close and do an ultrasound and make sure you're not missing a fine VFib. Because in that case, the patient actually has a pretty solid prognosis if you manage it as a shockable rhythm. So if it's asystole, make sure you're not missing a fine VFib. Otherwise, you want to do high quality chest compressions. And then ACLS is less helpful here. On the shockable rhythms, there's a very clear algorithm to follow. On this one, there's a box that says treat reversible causes. And ACLS teaches you the H's and T's. H's and T's are garbage. I don't ever remember those in a code. And even if you do, it's like third order thinking to get from the H to the intervention that you need to do. So here's how I think about PEA and asystole, and I don't miss anything. First of all, medication-wise, I am going to give epinephrine. Usually, this is a massive MI that's thrown them into PE or asystole, in which case their prognosis is fairly grim. However, if I can get enough organized squeeze together and enough peripheral vascular resistance to get some blood flow, get ROSC, maybe I can get them to a cath lab. And so I'm going to do that with epinephrine. So I am going to give epinephrine. The other thing, medication-wise, I'm going to consider is this hyperkalemia? In which case, if it's hyperkalemia or increased potassium, I need to give calcium and bicarb. Calcium and bicarb only for hyperkalemia. The COCA trial that just came out last year and some of their subgroup analyses suggested that just giving everyone calcium can cause harm. So you shouldn't just blanket give everybody calcium, but think about hyperkalemia. The patient's undifferentiated. Look for a dialysis fistula. Look at your EKG tracing. See if it has suggestions of hyperkalemia. If you suspect hyperkalemia, then do calcium and bicarb. These are all the drugs you have to remember for PEA. Epinephrine for everyone. Think about hyperkalemia. And one of the first things that I do when they come in is I run my hands up their arms, feeling for that dialysis fistula, and I make sure I'm processing, is this hyper-K? If we have them in the chart and we have records, I'm having someone check, do they have a history of renal failure? Do they have a history of high potassium? In which case, I'm going to give calcium and bicarb. CPR through all of it. I'm going to give epinephrine. I'm going to consider hyper-K. And the next thing I'm going to do is a focused ultrasound exam during my pulse checks. We're going to start with the probe in the subxiphoid position, trying to look at the heart. And the things that I'm looking for on the initial pulse check are 1, tamponade. If that heart is squeezing really good, and it's squeezing super good, and I have this huge effusion that's not letting my right ventricle open and fill, if I drain that immediately, I'm actually probably going to get ROSC immediately, but I have to identify it quickly. So that's the first thing I'm looking for with that subxiphoid view to see if they have tamponade. Second thing that I'm looking at the initial is this pseudo PEA. So we think hypovolemia as one of the H's and T's. You can actually have hypovolemia so profound that the heart is pumping and squeezing really well. It's just not filling because there's no volume to push through. In these cases, if the heart is fully squeezing but nobody can feel a pulse, compressing a heart that's actually squeezing is not of any value. The right answer is I need to be dumping fluids into this patient. If I think it's hemorrhagic, I need to get blood in this patient as quickly as possible. So the first thing I'm doing, first pulse check, quick subxiphoid, looking for tamponade, looking for pseudo-PEA. If it's tamponade, I'm doing an emergent pericardiocentesis. If it's pseudo-PEA, I'm pouring in fluids to this patient as quickly as I can. The next thing I want to think about is this a tension pneumothorax? Quickest and most accurate way to diagnose this is ultrasound. You can quickly put the probe on the lungs. What I do is I start while I'm compressing. While my compressions are going on, I look laterally. If you have B lines in the lungs on ultrasound, you do not have a tension pneumothorax. While you're compressing, it's difficult to evaluate for lung sliding, but while they're compressing, I'm looking laterally, more towards the bases of the lungs, looking for any B lines. If so, that rules out a pneumothorax. And then my second pulse check, I'm looking at the lungs. Breath, looking for lung sliding. If you don't have lung sliding unilaterally, in PEA, ventilate the chest. Whether you do a needle decompression or what I do is I take a scalpel, cut down to the rib, take a blunt instrument, poke over and open up the hole. That's enough to relieve the tension if you have a pneumothorax. So I'm doing a focused ultrasound exam. The first pulse check, I'm looking for tamponade or pseudo-PEA. Second pulse check, I'm looking for a pulmonary embolism. The things that misses are 1, a PE. And you may be saying, well, Steve, I can evaluate for a blown right ventricle to see if they have a PE. There's actually evidence to show that all patients in asystole and PEA, the right ventricle can dilate and balloon. So just because your right ventricle is dilated doesn't necessarily mean you have a PE. But what I can do is look and see if you have a big red swollen leg, or take my ultrasound probe and look at your femoral veins to see if I see clot there. Because if I see clot there, I can assume that it was a PE. In which case, if this patient is still survivable, I need to get emergent thrombolytics and give them while we're coding the patient, while we're continuing with high quality chest compressions. The other thing that this misses is hypothermia. What I'll say about hypothermia: if you get cold and die because you are cold, you are not dead until you are warm and dead. However, if you die, you have a massive heart attack and you die, and you lay there and you become cold, you are dead. So you really need to get some suggestion of this from EMS history, and there has to have been some signs of life with the patient. I had one of these when I worked in Ohio. A patient was walking out to their car. They found this patient later in a foot of snow. When they got there, the patient was in PEA. It took some agonal breaths, coded the patient for 45 minutes, got them cannulated for ECMO, rapidly rewarmed, got ROSC, and that patient walked out of the hospital 2 weeks later. I say this to say, for hypothermia, you've got to get this from EMS history. Were they an elderly person who had the house really cold and were alone? Did they have their power cut off in the middle of winter? Were they found outside in winter and been out for a prolonged period of time? Was there frigid water that they had been submerged in for some period of time? You got to have a history to give you hypothermia. This covers it. Now, yes, there's some of the H's and T's that I didn't mention, such as the H+, acidosis. Bicarb is not the answer for that. Giving bicarb can actually make intracellular acidosis worse. The way you treat acidosis in cardiac arrest is really good BLS, really high quality chest compressions to perfuse blood. That's how you treat acidosis. If you do this focused approach to PEA and asystole of, I'm going to give epinephrine, I'm going to consider hyperkalemia, I'm looking for a fistula, I'm looking for any history of hyper-K. If I have any suggestion of hyper-K, I'm going to give calcium and bicarb. That's the meds portion of it. Then I'm doing focused ultrasound. First pulse check, looking for tamponade or pseudo PEA. Second pulse check, looking for a pneumothorax. And then finally, I'm considering PE. I'm looking for a swollen leg. I may do a vascular ultrasound of lower extremities to look for a blood clot there. And then on EMS's history, I'm listening for anything that could suggest hypothermia as the cause of this cardiac arrest. Shockable rhythms, shock, epi, shock, amio. That's going to get you through most of them. For non-shockable rhythms, epi, consider calcium bicarb. Look for tamponade, pseudo PEA, pneumothorax. Think about PE and think about hypothermia. That's it. That's going to get you through the basics of managing patients in cardiac arrest.